All right, Kinesiology 230, Chapter 20, Clients with Cardiovascular Respiratory Conditions. This is Presentation 2. Turn focus towards myocardial infarctions, commonly known as MIs, stroke, and peripheral artery disease. We're starting off on page 553 here, so let's get rolling. When we talk about like the what's called the pathophysiology, right, for all of these, it's essentially the same. It's a matter of you have plaque that forms within the lumen, of the blood or the actual vascular system itself. It's the open space within the blood vessel. So if you can imagine a blood vessel like a pipe, it's that inside open area, and blood flows through there nice and smooth. And you want what's called laminar flow. Laminar, like laminated, like you laminate a sheet of paper. It's like a layer on top of layer on top of layer, and it's blood flowing nice and smooth. The little blood platelets and the fluid itself has a viscosity to it, and it's flowing nice and smooth through that pipe. But as soon as you have a little bit of plaque on the inside edge of one of those pipes, little currents as the blood that's flowing through hits that, and it causes like an undertow, if you will, or an undercurrent. And what happens with that is the little platelets start to stack up, they start to calcify, they end up with atherosclerosis, and collagen develops over that inflamed area, and it disrupts that laminar flow. So what happens is though it gets worse and worse and worse and worse and worse, and until eventually you have blockage. And the blockage, whether it's myocardial infarction, a stroke, or peripheral artery disease of some variety, is a result of a blood clotting episode or atherosclerosis. And I know this is going to be seen later on. So they talk about the collagen cap and how it causes diameter of the blood vessel to get smaller. They give you a rendering here in the book, and I think it's really not that good, to be quite honest. If you can just visualize a pipe that has like a clog in it, that's usually the best way to visualize this whole process. But the clot itself, you have this blood clot that is referred to as a thrombosis. You may have had a family member who had what's called a thrombosis. That can be a very serious condition where a DVT can cause blockage in the blood. If that clot were to break loose, or a blockage in the heart or in the brain or somewhere else in the. So they do this, and it ties into a lot of different things that we always talk about in terms of exercise and nutrition, and we'll see that here in a moment. So the collagen cap itself, they talk about it's soft and unstable. It can rupture, and the released material then can flow downstream and cause this occlusiveness or an occlusion somewhere else in the system. And when you have mature collagen caps, they don't rupture as easily. It's almost like it's a hardened like scab, if you will. So the big point that you have here is the collagen cap itself can, you'll hear the terminology, throw a clot. I threw a clot. And a clot itself makes its way through the body and it gets to the heart. And perhaps you have a myocardial infarction, meaning infarct is myocardial, meaning the muscle of the heart, myocardial. Infarction is a occlusion or a disruption of blood flow to that area. And the terminology that you have, it's really called pectoralis angina. They list it as just angina down here. But the actual terminology would be specific to an area, because you can have angina in different areas of your body, just that pain. So pectoralis angina, you'll see in a later date in this class that you'll be asked about angina. It's normally typically tied to chest pain, and that's just from insufficient blood flow to the heart. So the risk factors for atherosclerosis include things like diabetes, high blood cholesterol, high blood pressure, obesity, tobacco use, family history, lifestyle. And you look at this and you go, okay, what are the things that are controllable, right? And we know this risk factor for cardiovascular disease algorithm, and these are provided in another class pretty far in depth. If you've not already had like 231 or 230, mostly 231 is where you'll see it, but a little bit in another class in 214, but it's predominantly in 231. It's about finding contraindications to exercise. I'll say it again, with most of these conditions, if it's type 2 diabetes, exercise helps. If it's high blood cholesterol, That would be a nutritional thing. Perhaps it's also a fitness thing where we can move a little bit more. Same thing with blood pressure, obesity. These are very much behavioral related types of risk factors, and are things that can be dramatically affected by exercise. And it's a matter of when you have somebody who comes in who perhaps was given a very poor message by their doctor, they are left to come to you to help them resolve the issue. And you have to be very good as a professional providing them the information that, hey, you got here due to lifestyle choices. Now we need to make some new lifestyle choices to get you out of this mess. I wouldn't say it like that. I'd say a little bit more professional, but you get my point. Now, the thing that you'll see here later on in these two highlighted passages, you'll see these both later on in terms of quizzes and also test questions, is the other one is people who are obese require more blood vessels to feed the adipose tissue. Now, we know that people who are heavier have to carry around more weight. Now, that is tissue. Adipose tissue is just that. It's just fat tissue. But it requires servicing by blood vessels to feed those tissues. And now this basically increases the cardiac workload. It affects the circulatory efficiency. And so as a result, you have this kind of negative spiral when people are obese. So people who are obese, they work harder to move around because there's more of them to move around, but they work harder to move around, not just by carrying around, but the weight itself puts a specific tax on the circulatory system and the other systems of the body to be able to function correctly. And it's not something that happens overnight. It takes a little bit of time. All right, so when we look at coronary artery disease, when a person has a blockage or that occlusion of blood in the heart, this causes pectoralis angina. That's a chest pain. And, this lack of blood, this causes basically like a dying of cardiac muscle. You're not servicing the muscle itself with enough oxygen or nutrients to be able to effectively function. You'll have clients who no doubt who have had heart attacks, and I hope to God you never have a client who is having a heart attack. In my entire career, thank God, I've never had to intervene on that process, but I've had coworkers who have, and they had to whip out the AED and save the person's life. Almost with great certainty, much like I mentioned with blood pressure in the previous presentation, you're going to have somebody come in who had a recent MI, who had cardiac arrhythmia, who had some type of pectoralis angina, who went to their doctor, and the doctor said, hey, time for you to get up and get moving, and they come to you to be able to solve that problem. And so you have to understand that if they've gone through, in the worst of cases, perhaps some type of bypass surgery or angioplasty or something to resolve an issue in their heart, then they've probably gone through cardiac rehab. And if they've gone through cardiac rehab, then they come to you. They should be cleared at that point by their doctor and anybody in the cardiac rehab process. But I will say this, once they get past the cardiac rehab process, you may have some medical recommendations and guidelines then that will come from the doctor or the rehab specialist. And in some regard, it's to your best interest to be able to reach out to that person. Even if they don't get back to you, you've made the effort. And God forbid, and I hate to say this from a litigation standpoint, but you're working within your best practices to try to reach out to the professionals to pick up the torch, if you will, or pass the baton from them to you in terms of working with your client who clearly had a heart condition. Now, on the other side of that equation, if you have a client who comes in and they're describing chest pain, angina, they're describing some symptoms that are correlated to possible heart attack, then you don't want to train that person, right? You want to send them off to the doctor right away. So there's another side to this equation that we have to talk about in terms of your person comes in, they have clearance from their cardiologist, you have already talked with the doctor, or at least you have some kind of information. Usually it's some kind of communication from the doctor in terms of like paperwork or suggested exercises or things that your person will walk in. They'll carry it in right into the initial consultation with you and say, my doctor wants me to do these things. And you integrate those things in because that's what the doctor ordered. And you as a professional probably don't have an MD after your name in cardiology. So, you implement those things in And as you get into your training sessions with your client, you implement those things in, you put in your own exercises, and you eventually transition into just full-time training and program design on your side once the doctor has released that person completely. So they note that the program that you create should be sent to the doctor for approval. I will tell you that in practice, this is something that just does not happen. Those folks who are cardiologists will probably not have the time for somebody outside of their scope of practice. And I would just say, as long as you have the initial paperwork that they bring from their doctor and you've made the effort to reach out to their doctor, whether or not they get back to you is another story, and just keep track of what you're doing on the front end, and eventually it becomes a matter of they will no longer have to have the same contact level of contact with their cardiologist, and it becomes your client, your training session. It's no longer you're servicing somebody who just went through cardiac rehab. Now they talk about the abnormal signs and symptoms. It's a typical things that you'd see, like when a person's having a heart attack. It's chest pain, palpitations, shortness of breath, nausea, neck pain, arm pain, back pain, sense of impending doom. These are all things that are consistent with having a heart attack. Now, the components that they talk about, and this is something you'll see later on, the recommendation for aerobic conditioning is 3 to 5 days per week of 20 to 60 minute sessions at an intensity of 40 to 80 VO2 max of heart rate reserve, or an RPE of 12 to 16. I will say this. It depends upon the person, right? If a person is familiar to working out and they had a heart attack and then they're coming back to you, this will be something that'll be, you'll be able to push them a little bit more than the people who never worked out before. It's very much like when we were talking about our clients who come in who are pregnant and they were worker-outers before pregnancy versus people who didn't work out and now they're pregnant. Same thing with your individuals who have had recent heart attack. They will have greater familiarity with equipment, workloads, effort, etc. And you can probably nudge them along at a higher level, and a higher level sooner in the workout programs than somebody who has never worked out before, who is probably just scared out of their mind to be there in the first place. You got to have monitoring signs like we talked about. You got to figure out how you can have communication between you and your client to let them know that they don't feel good or they need to sit down, or find ways to articulate RPE and have them become more familiar with that scale, and also guide them to let them know that RPE is a little bit of a moving target as they get fitter. So with that, I'm going to sign off and move to the next presentation later on.